and we'll take a look at it. I've got to get the chat window open on my computer. There it is. Because when I changed things, it dropped it off of there. So um, let's just get started. So these are in no particular order, but they are topics that are controversial, and some of these have been controversial for a long time, some of them have not. Air medical is one that has been controversial for so many decades that it's unbelievable. I mean, even when I was a paramedic, this was one of those where the flight crews were like, well, if you ever have a doubt, just call us, we'll take them. And so it's always one where you got to try to figure out what's best for everyone. So the question is, when should we fly the patients? Is it because of time? And that actually can be, you know, time to a center, but it can also be in urban areas sometimes the time of day, because if everything is gridlocked and you can't get to the hospital, then their medical crew would tell you, well, that's a time that you should call us, even in an urban area. How about the distance? Obviously the helicopter can fly at about twice the speed of what an ambulance can drive. And generally it's safe to say, okay, from liftoff, from the scene, if you're going to take, say, an hour to get to the proper destination, the helicopter from that same scene generally can make it in half of that time. So that's one of the other questions, is the distance and that time. And then this one is one where we kind of start going smooth transport. I actually had an MVC patient just last week that was in a bad truck accident, and he had a C6 cervical fracture, and we needed to get him to a level 1 trauma center. Had several other things going on as well. The smoothest way to transport them is actually by air. So cervical spine fractures, that's something where you probably should consider whether or not they need to fly. One of the things for me that has always kind of been controversial and something to talk about is, why is it that this helicopter is such an essential thing, except when there's clouds and some weather? And, so in those situations, we're expected to go ahead and take the patient. you know so that's always one of those things that has kind of rubbed me the wrong way about air medical. The other factors in the time argument have to do with, is it truly a time sensitive issue? And so surprisingly, for most of the things, in my opinion, the time sensitive issues are actually cardiac and stroke, because those truly are, you got to get a definitive treatment for them if you want to reverse that process. So even more so than trauma, because we can talk about the golden hour at some point and some of these other myths, but the golden hour is actually from the time of injury until some treatment is begun, and that includes us, putting on a bandage, starting an IV, doing something to stop the bleeding. It's the marketing ploy of they need to be in the operating room within an hour was actually one of the R. Adams Cowley's things that he came up with to market the shock trauma center in Baltimore, was the golden hour. It was actually, like most EMS ideas, it was thought up at a bar. So now, then the other thing is specialty care. Now, the specialty care may have to do with things like, you're anticipating a problem with a pregnancy, and they need a specialty area that is far away from you. It could be also a trauma center, a stroke center, a cardiac center. So there are a lot of different things that you need to kind of consider, okay, what is the proper place for this patient? Now, let's talk briefly about reasons to not fly a patient. Are you really saving time? I'll tell you anecdotal story from the hospital. I was at the hospital in Weatherford here, and I'm the EMS medical director at the time. And I have a stroke patient, and I call the tertiary care center, and they said, "We'll take the patient, but only if you fly them to us." And I said, "Ma'am, I'm looking at the back door right now. I've got an ambulance base right there with 3 staffed ambulances, and they're all there. We can actually pick this patient up and have them to you in 22 minutes." And she said, "No, it doesn't matter. I want you to fly them." And I'm like, "We'll have this discussion later. It should be my decision how we're going to send them. But if you're going to take my patient, I'll get them there." Well, turns out that the helicopter got there 30 minutes later, and they were on the scene for about another 20 minutes. And then they finally took off, and it took them 10 minutes to get downtown. And so the next day, I'm talking with their medical director, who said, "Absolutely, you were right. You should have been the one to choose how they got here." And I said, "Well, how'd the patient do?" And he goes, "I don't know. Let me get you to the stroke coordinator." So the stroke coordinator comes on, and I said, "Well, how'd the patient do?" And she said, "Oh, complete resolution of symptoms." I'm like, "Well, that's great. Got TPA, huh?" Said, "Oh, no, no. Everything went back to normal while they were in the helicopter." So if we had actually driven the patient there, they probably would have gotten TPA, and it would have been a, "Hey, look, TPA does wonderful things." So, the question is always, is it really going to save time? And from a pre-hospital perspective, you need to look at those places and go, okay, from the time that a helicopter can get to me, how long is it going to take them to get here? Then once they're on the ground and they're doing their stuff, and then they take off, what really is the time? And so, even as far back as when I was a paramedic, the question was always, if you're going to save 20 minutes transport time, then yes, flying the patient is probably appropriate, especially for trauma. But if it's going to be more than 20, if you're not going to save 20 minutes, then you probably don't need to fly them. So, you have to take into account extrication time. You have to talk about, the treatment that you're going to provide, that they're going to provide, those sort of things. Are you leaving an area uncovered? This is actually a big reason in the rural areas why they'll say, "Well, we're going to fly them." Even though they're not really that serious, we're going to fly them because we can't leave our service area uncovered. I need to get with Brian Bledsoe, Dr. Bledsoe. He has a great series of EMS lectures called "The Myths of EMS." One of them is this, about leaving an area uncovered, and he actually has some data to support the fact that that second call that they always are afraid of generally doesn't happen, especially in those small town rural areas. You just really don't usually have another call that is going to go unanswered because you're driving a patient somewhere. The cost. A few years back, there was a series of articles in the news about these people that were getting $7,000 and $10,000 bills for being flown somewhere. There was a case of a patient that was flown from the Southwest Fort Worth area to Parkland Burn Center for a burn on their legs that were second degree burns, and they actually walked out of the hospital that same day. And they ended up with, I want to say it was $7,000 bill. So, there are a lot of costs that are associated with this. And if they're not a member of those services, and I am not, I live in a semi-rural area, I drive long distances, I am not a member of any of the air medical services, then anything that their insurance doesn't cover, they actually are very aggressive in their collection practices, and they will file liens against you, and they will take you to court. So there is a real anticipation of what is the cost. So can the patient consent? I've had some of my crews that have called and said, we were going to fly this person, and I actually agreed with the reason for them to fly them, but the patient was refusing. So there, and it was usually over cost. And so there is really a concern about doing something against a patient's will. And so, in some cases, they have threatened to sue the pre-hospital providers for doing something without consent. I don't necessarily agree with it, but it's there. Level of care. I remember sitting in a meeting where an Air Medical Services CEO was there, and he was talking about how they can bring a neonatal resuscitation team in their helicopter, and they can bring a respiratory therapist, and they can and bring an isolette. And I actually stood up in the meeting and I said, "You're not going to bring those on a scene, so really you shouldn't even bring that up." And he got very angry at me, which I don't care. But so there is some question of level of care. Now, the other thing that will come up is, well, we don't have RSI capabilities, and they do. And that is actually sometimes a valid point, but once again, you got to factor in those time savings. The hazards. Now, this is a hazardous thing. You all know that what we do, there are certain risks that we take when we respond to calls, when we're on scenes, when we're driving to the hospitals, those sort of things. Um, Same thing with the air crews. Now, there is a big difference. Everyone says, yeah, but flying is safer than driving. That is true for scheduled airlines. It is not true for air medical. Now they've had quite a while where they have not had crashes. They had a couple, I know, in 2019, and I think that there was one not long ago this year as well. But just keep in mind that the crew is risking their life, and you want to be sure that there's a good reason for it. There's a risk that they could crash on your scene. And when I was a dispatcher, I actually did dispatch a crew to a MDC north of Fort Worth where care flight had taken off, hit a power line, and then slammed down hard and rolled onto the same scene that they had just taken the patient out of. So it can happen. Then there's also persons on the ground. We hear about these helicopters crashing, and it's usually in a remote area, and they're not on radar or anything like that. But it can also happen that they end up hitting a building or a house. So there are people on the ground that they had nothing to do with this. They never agreed to these risks. So we really need to consider all of those factors when we start talking about whether or not we should fly a person. It is not a benign sort of process. Any questions about that one?
Yes, sir.
Okay. So pre-hospital hypothermia. Anybody doing anything from that perspective in your services where you get a cardiac arrest and you get a return of circulation, and so you institute a hypothermia protocol?
We used to, but we've discontinued it.
Just curious why.
I am unsure. We are suburban EMS,
Right.
so it might be the time distance.
Okay. Well, actually, there's some good reasons. First off, it is a very well established principle in patients that have ROSC. The issue becomes one of, are they awake or not? Are they moving? Some of those sort of things. And so sometimes you end up having to paralyze the patient to keep them from shivering. Otherwise, their temperature is going to go up. Plus, it creates a lot more acidosis. So there's some principles there. How is it done in pre-hospital? Because the way that the hospitals do it where I'm at is that they put a big femoral central IV in, and it actually circulates cold water, and it takes it in, cools down the blood near that line, and then runs it back out and cools it down again. And that's how we get them cold. There are some of these things are called, one of them was called the Arctic Sun, where they actually put these pads on them and that turns them down. Um, I had looked at for our service saying, okay, if we get ROSC, let's just have a supervisor or somebody always have, some 10-pound bags of ice, and we'll just start icing them down, and we'll, see about some little refrigerators, and we can put saline in there and keep it cold. And it's one of those where, just we never actually got it off the ground. I'm glad that we didn't. So uh, now, Weber, I don't know what the C is for. I'm sorry, but I agree. The rural areas. I really kind of think you probably shouldn't. And the reason for that is the same reason that you don't want to um, take frozen meat, let it thaw, and then refreeze it. It's been shown that in these patients, if we let them warm up and then cool them back down again, that actually they have a much worse outcome. So I agree with that. I had been a medical director in Graham, which was very rural as well, and we never did the cooling either. So, and Christian, good. I'm glad to know that. I'd heard it, but I just couldn't remember tonight. So the next thing is it effective? And really what to me that means is, does it make a difference? Overall, if we get ROSC in the truck, does it make a difference in their 30-day mortality, whether or not we cool them down or we wait until we get to the hospital? And it's actually been shown that no, there is no difference. So it's not necessarily a bad thing to do, but it doesn't make a difference and it doesn't affect the outcomes. So really it's one of those where there are quite a few services that either are doing it or have done it in the past, and they either stopped or they may still be doing it, but I haven't worked in a system where EMS is doing the hypothermia. Okay, now we're going to step on toes. Intubation. So, when should we intubate? That's always a big question. What is the success rate? And more important, what exactly are we measuring and how is it being measured and reported? Because first off, I'm interested in a couple of things in particular. Number one is first pass success rate. Okay, well, I know one systems medical director where he doesn't define it as an attempt unless you try to put the tube in. So you can have people, looking several times, and that doesn't count as an attempt. So I want it to be with my guys that if you put that scope in and they're not breathing, that's your attempt. And so I want somebody to time it, another person on the scene, not the one holding the scope. And I want them to tell me, how long it took, how many attempts it took, and what happened with the pulse ox. So those are the sort of things that I'm interested in as a medical director. Then the next question is, what do you do with that data? We're actually in the process of making that public information, so to speak, within the stations. So in other words, you go to one of our stations and I want to have the first pass success rate for the last year for everyone in the agency, right up there for everyone to see, names out in the open, because competition is a good thing. Now, we have a first pass success rate that's around 85 to 90% for across all of our providers. And that's actually an excellent percentage. There have been several studies that show that depending on skill levels and just the overall situation, when they're doing these intubations, that a lot of EMS agencies are 50% to 60% on their first pass success rate. So that's not good. So we need to keep in mind that these are things that we need to keep up with. What about a BIAD, blindly inserted airway device? How about doing those rather than an endotracheal tube? How often do you have to go to those? There's times that I kind of consider, should I actually take intubation away from CPR? If we're doing CPR, it's a lot faster to put a blindly inserted airway device in. And there have been studies that show that it's as good as endotracheal intubation. You do have to intubate them after you get ROSC, if you get ROSC. So, there's pluses and minuses to all of those things. Then the question is, well, what are you going to use to put it in? Direct laryngoscopy versus video laryngoscopy. I will tell you right now, and consider this a standard of care statement. You should be able to use anything that is in your unit. And so to that fact, when I started at another hospital in 2019 up in Ohio, first time that I went to do an intubation, the respiratory therapist was like, so what do you want to intubate them with, the glide scope or direct? And I said, you pick. They're like, what? I said, I should be able to use anything that you have here. You pick, surprise me. And so there were times that, I prefer a straight blade, but sometimes they would hand me the glide scope. Sometimes they'd hand me a curved blade. And I like that. I want to be able to use everything that I've got. And unless you do that, unless you use those things different times, you're not going to be proficient with it. So you can't always do it the same way every time, especially on the simple things. I had another doctor that worked for me in an ER that I relieved him on a Saturday morning. He said, Don, I had a really bad intubation last night. And I'm like, what happened? He starts telling me, and it was a young girl with asthma. And I said, well, even with the glide scope? And he goes, I don't know how to use it. I said, we've had it over a year. You've intubated since then. He goes, yeah, but I've never had a difficult one. And I said, but you had a difficult one last night and you didn't know how to use it. You need to use it on the simple ones. And so when we actually deployed video within my agency here in Parker County, I told the crews for at least a year, every time that you intubate somebody, that first attempt has to be with the video so that they get that experience with it. So I would encourage you to use everything that you have at your disposal. Don't wait until you're in a corner to try something different. How about bougies? There have been a lot of papers that have shown that people, and this includes physicians, CRNAs, anesthesiologists, as well as pre-hospital, the people that use a bougie first time, every time, have a higher first pass success rate. Now, this drove the same respiratory therapist in Ohio nuts because I said, where's a bougie? Well, it's on the difficult airway cart. Well, that's an even better question. Where's the difficult airway cart? Well, it's over in storage. Do you think this is going to be difficult? And I said, no, but you never know. You should have it available. And so they actually started putting bougies at every bed so that if we do an intubation, it's there. So and the other part of that was I said, listen, I mandate it with my crews. If they're going to do direct, they got to use a bougie. No option about it. You got to do that. And there are plenty of papers that show that people that have 90% first pass success without a bougie will go up to 95 to 99% with the bougie. So, it's an easy tool to use and it really does help your success rate. So use everything that you've got if you're going to do this. How about RSI? I know that it is part of the curriculum, but I've got some of my medics that say, I really don't want to be credentialed for that. And in my service, it is a separate credentialing. I don't say that every paramedic can do that because I want to be sure that they are going to be able to get the tube most of the time if they're going to paralyze somebody and take away all of their protective reflexes. So it's a controversial area. So you got to know what the risks are. You got to know who should do it. And then the next question is, how is it taught? I mean, we actually have a 2-day program for training people to do RSI the way that we want it done, so that we know that they're doing it the way that we want it to be done, that are going to increase their success rate. So I would say, these are all questions that you need to ask. Now, I was actually talking with one of my training people just last night, because totally separate thing. We're going to touch on it in a minute. And his question was, you know, that what we're talking about, the other item is a 2-year education process to learn how to do that. And oh, okay, Andrea, I'm sorry. It may be my internet. I'm not in a country area, but we're on the fringes. So sometimes that may be my internet causing that. Um, but the issue is, should we do this because, hey, are we really going to be competent to do this particular procedure? The same discussion was taking place about RSI when I was a resident. It was actually controversial for somebody other than anesthesia to do an RSI. And in fact, the champion for RSI when I was a resident was actually an emergency physician that had trained as an anesthesiologist before starting emergency medicine. So, you know, we've come a long way, and we don't want to do anything that's going to damage our reputation. And RSI still is relatively young as far as emergency medicine goes. That was in 1992 that I heard about it the first time. My trainers didn't know how to do it. So, it is something that is relatively new. And then how is it monitored? That for me is one of the biggest questions, is how are we making sure that people are doing this appropriately and that our success rate stays as good as it has been? Now, the next one, this one, there's actually paper from I want to say it was from the early 2000s by Mary Ann Gausch out in Los Angeles, where she looked and said, should EMS be intubating pediatric patients? And they actually came down with some comments that said basically, no, we should just do BLS airway management for pediatric patients. And there's a variety of reasons, but really the biggest reason comes down to paramedics don't do pediatric intubations well. The success rate is very low. So, it's one of those where you kind of got to weigh all the factors. And, frankly, in my career, I've not intubated very many children. And most of us that are on the adult side and in pre-hospital have not. So pick your battles. If you think that you're not going to be successful, then you probably need to stick with basic maneuvers. 12 lead EKGs. This is not really up for debate anymore. I'll tell you that when I started in EMS, we had 3 leads, 1, 2, and 3. That was all that we had. We only had 3 patches that we stuck on them. And so times have changed a lot. The first time that I saw a pre-hospital 12 lead EKG was when I was a resident. And at that time, they actually had a thing that their biomedical department had put onto the monitor, so that they had a little selector knob to be able to do all the V leads. And so they really only got 9 leads because they weren't getting the augmented leads. So, times have changed a lot. And even in 2001, and when I became a medical director for the first time, that service was just deploying 12 leads then. So think about how this has changed in 20 years. So the next question is, does a hospital that you're sending them to actually put out a pre-alert? If you call and say, I've got a STEMI, are they requiring that you be able to send them the EKG before they'll activate? Because, there are some of those places that will do that. Now, if I'm on and they say, hey, LifeNet is calling and they've got somebody that's a STEMI, I'm going to activate the cath lab, because I would rather activate the cath lab and have everyone starting in and then say, no, cancel, than to lose that time. But there are equipment costs associated with that. You have to have the right software. The receiving hospital has to have the right software, depending on the manufacturer. So there are some costs associated with it. Christian, I agree. There are a lot of places that are doing eye gels or any other blindly inserted airway device, especially in some of those difficult situations like the cardiac arrest and in pediatrics. The transmission ability, and then the training and competence. It's probably a little bit different as we've grown in this, but early on, it was constant. You had to, do a lot of quality assurance and looking at the EKGs and looking at the interpretations of them. So it is something that is kind of changing quite a bit because it is so out there now. So Andrea, there are some of the software that you can actually send through cell phone. I remember actually when they switched over to all digital for cell phones, that some of the software wouldn't work except on an analog line. So, times have changed. Now, I would say whoever your service administrator is needs to contact your monitor company and see if there is some way that they can fix that, or make sure that the hospitals are aware of that and they're willing to still activate. So, termination of resuscitation. We've started this in my service area, and actually they're responding to a cardiac arrest with CPR in progress right now. We have started termination of resuscitation. We have a specific protocol for it. And I remember another medical director stating that we should not be transporting dead people to the hospital. And I tend to agree with that, and there's a variety of reasons. First off, the next question is, what is the rate of ROSC in your service? Part of that has to do with where you're at. So, is it a very rural area? What is your response time? What's the chances that there's going to be bystander CPR going on when you get there? So there are, and does your service have medical priority dispatch so that you can talk somebody through doing CPR, even if they have never done it before? So there are a lot of factors that go into that. And, frankly, my service area, we have a mixture of suburban and even to some extent urban, but a lot of rural areas. And we've got a lot of areas where it's 15-minute response time. So, those are some of the other things that have to be considered. What are the 30-day outcomes for your area? If you do get ROSC, what's the chances that they're actually going to survive 30 days, or the Utstein criteria? And then I'm assuming that you have all at some point done CPR in the back of a moving ambulance. The compression quality is terrible, and especially if you're the only one in the back. And so, Andrea, that rural area, been there, done CPR and as a BLS, how do you go from, well, now it's not that big of a deal, do hands only, put an honorary breather on them, but how do you go from doing compressions to ventilating the patient, and then at a paramedic level adding on drugs? So the quality just isn't there. And then how feasible is all of this to happen with a single crew member in the back? That's what we were just talking about. If you've got first responders, they can help, but it's still difficult. And it's also very taxing on your people. How about mechanical CPR? We actually have Lucas devices here. I love them. I think that they're great. The studies would say that there really is no difference between mechanical CPR and hands-on CPR as far as the outcomes go. And so places where they're trying to cut costs will say, well, we have no reason for this machine to do this because it's no better. That's when, if it's my service administrator, I'm going to go, or somebody that's not EMS, I'm going to say, okay, tell you what, let's get you to do CPR in the truck on a mannequin while we drive. And we won't even drive code. We'll just drive around. And usually that's all that it takes to say, okay, maybe we do need this. And then what the big question is, and I still struggle with this, what do you do when they're in pulseless electrical activity? Is it that they still have a pulse? And what if your crew pronounces them and then clears the scene, and then somebody comes and says, well, hold on, they're breathing, because it happens, and it happens way too often. So, it's one of those gray areas that's hard. And so, those are some of the struggles that I had when we started setting this up. What is the disposition of the body? I'm in an area where we're covered by the Tarrant County Medical Examiner's Office. So they have a medical investigator that will come out to the scenes on these and do a quick look and everything. So that's in place. We also have of course law enforcement, but these issues have to be considered when your medical director is talking about, should we do a termination of resuscitation? What if it's in a public place? You can't just leave a body laying somewhere, say in a mall or at a restaurant. You know, we don't. In those cases, they're going to transport that person. But we might not be driving. Oh, we will not be driving code while we're doing CPR. It's just not reasonable to do. And then the next one is, will it affect reimbursement? Because guess what? Right now, the way that the laws are written, especially for Medicare and Medicaid, if we don't transport, we're not getting anything. And so when we went to this, my service administrator was like, do you realize that we can't bill for those? Yeah, actually I do, but it's still the right thing to do. So Christian, have a Lucas on every ambulance. I agree with you on that. I think that that's great. And also because it helps as far as you're less likely to get injured by being thrown around. The first time that I ever had a CPR call, it was actually for Michelle. It was with the Frisco Fire Department when it was still a volunteer agency, and I had a firefighter in the back, and he actually hit his head on a hanging hook. It was in a high top suburban ambulance from doing compressions with both hands. And so, you can get hurt doing this stuff. And so, Christian, I tend to agree. I'm sort of the same way with mine, other than if they're in a public space. Unless you get return of circulation, I still have heartburn over those PEAs. That's still one of those things that I'm just like, oh, I tell my crews, take your time, write your paperwork up, stay there on scene, be there at least 15 minutes doing nothing to the body, and then come back and check and see if they're still in PEA. So, usually by that time they're not, but at the same time, my greatest fear is having somebody from say, hey, this is from Fort Worth Star Telegram, and we'd like to talk to you about that call that your ambulance service went on. That's a fear that I've got, right or wrong. So Michelle, we're coming to that. I like that. So new technology. Well, there are some places that actually have special ambulances for their strokes that have a CT scanner in the ambulance. I don't really agree with that. I think it's a huge expense and problems, and how do you pay for it? How do you get reimbursed? And you have to have a radiology technician with you. We cannot do these legally. We cannot operate x-ray devices. So, there's some issues with that. Video laryngoscopy, it has not been around that long. We're talking around 2009, 2010 is when it really started getting out into the field. Ultrasound, just like you were talking about, Michelle. We're gonna dive into that a little bit in just a second. Automatic blood pressure cuffs. Has anybody ever done a manual blood pressure with an instructor listening with a dual-headed stethoscope so that you're hearing what they're hearing and looked at you and said, that's not the blood pressure when you tell them the numbers? Because I have. And most of us never really got a really good education on what we're supposed to be listening for. Waveform capnography has not been out that long, and frankly, where I'm at right now, we only have 3 things that we can put into the monitors at any one time to do waveform capnography in our ER. So in general, EMS is ahead of the hospitals on that. New drugs. Some of them are really old. I use TXA as a great example. Everyone thinks that it's so new from the wars and everything, but TXA has actually been around for OBGYN for about 20 years. Well, more than 20 years, because it was already in their hands for probably 20 years before it went to the war on terror. Blood administration. And there's one of those things that everyone has an opinion on it one way or the other, and they're very dogmatic in their views. So I'm going to give you how I consider these things. And so it's only my perspective, but when my crews or somebody comes to me, or I'm at a conference and somebody says, oh, you should put this in all of your ambulances, these are the thought processes that I go through and the things that I ask. And I'll sometimes ask my crew, what is the cost? A lot of times, especially my paramedics, and I was that way as well, hey, that sounds really cool. We should do that. Well, what does it cost? They don't know. So that's the first thing. You got to find out what the cost is. And it's not just the cost of the device, that's a small part of it. The acquisition of the equipment or the medicine is just a small part of it. You also have to have training. And so, that may entail, for some things, paying to have people come in on their day off to get trained. The recurrency, making sure that people are still competent to use whatever it is. If it's a drug or something, there's expiration dates, you have to restock it. How hard is it going to be to get replacements for whatever you need as far as consumables go? Ventilator circuits, those sort of things. So, those are some of the questions that I ask about cost. And how often can we reasonably expect to use it? I don't remember the exact thing that it was that somebody came and said, oh, we should put this on every one of our trucks. And I'm like, how often do you think you're going to use that? And once again, I can't remember exactly what it was. And I said, I've been doing this over 20 years and I have never seen a case of it. And so that kind of stopped that right there. Same thing with, should we be stocking a very specific type of a steroid for people that have congenital adrenal hyperplasia? It's not really an expensive sort of thing, but it's going to expire. We're going to have to replace it. And the bottom line is it's considered to be a rare disorder by the government. The numbers of people affected are such that I did the math when somebody was talking to the GTAC Medical Directors Committee, and I said, my county population is this, and this happens in less than 1 in 10,000 people, which means that there's going to be 2 people, I think it was 2 people in my county that have this. If you'll tell me who they are, I'll just call them up and be sure that they have it. And she didn't see the humor in it, but at the same time, if you're not going to use it very often, then, is it really going to be worthwhile? Will it change? Will it change a lot of things? Will it change my destination? Will it change what I'm going to do for the patient? And will it change them to where they're getting appropriate care faster at the receiving facility. And that comes back to the same thing that we talked about with the 12 lead EKGs. Are the hospitals going to actually respond to what we tell them? If we tell them that, hey, there's blood on the fast on an ultrasound on a trauma patient, are they going to have the OR waiting? I don't know. Will the service be able to be reimbursed? If you don't know, Medicare right now pays pretty much a flat rate of $350 for ALS care. That's it. You can bill $1,000 for a cardiac arrest. You're only getting $350, and that's if you transport. So you have to consider those things. And can we get enough of this to be able to supply it in all of our units? Is it a technology or drug or whatever that is accepted by the medical community? Because there are some things that are still kind of considered fringe in some ways, but that has to be considered. And will you end up getting some pushback from the medical community if you do those things? So, there's a lot of factors that go into this, but I'm always willing to reconsider. I already had that same discussion about will it change all of these things with ultrasound. I had several company reps that came and said, you really need to put this in all your trucks. And my question was, is it going to make a difference? And went through and I'm going, other than PEA, I really don't see where it's going to change anything. And so we chose not to do that at that time. Now, I'm actually kind of changing about that. So, Michelle, I don't know where you're at. I know that in Wise County, they've had ultrasounds that have been mounted in their units since around 2008. And my issue with that is it's mounted in the truck. And so if they're going to take their PEA patient and see if they're really dead, they're going to have to take them to the unit. Now your unit is where they're being pronounced. And so it's now become a crime scene until the police or the medical examiner or whoever comes and tells you that no, it's not. So, that's one of the issues that I've got. I actually, I know the chief there at Plano. I used to work with Sam. So yeah, I know some people over there. So what can it do? Once again, early on, I thought that it was very limited. I'm starting to see some other options there. And this is some of the discussion that I had with one of my training people last night. How do we train and assure competence? Well, his point was it takes 2 years to become an ultrasound tech. We're not going to give people 2 years training in this. And I agree, but at the same time, we're also not going to be expected to do all of the same examinations at the same level of competence. We're looking for different things. What is the cost? In 2007, when I started looking at this, the cost of a sonocyte, which was the first truly portable, was between $30,000 and $35,000 each. And the probes cost around $3,000 each. And if you broke that probe or you broke the wires in the cord, the whole thing had to be replaced. It could not be fixed. Now, I actually have a handheld, it fits in my pocket, ultrasound that has dual heads that it can do line placement, it can do cardiac, abdominal, it can do Dopplers, it can do everything. And I paid just over $3,000 for it. So, the prices have come down dramatically. There are some of these I'm going to show you in a minute that are actually less than $2,000. Can we get reimbursed for it? Actually, the answer to that is probably not. The question then becomes, is it worthwhile? Is it the right thing to do? And so that really kind of is where that comes down. And what has changed besides the cost? One word, COVID. And I'll give you a couple of references for that in just a second. So I would ask you, when was the last time that you really cleaned your stethoscope? Certainly after you have a COVID patient, most of us are actually pretty good about doing that. But, what about the other things that can be transmitted? So you have to ask those questions. And can you assure the quality that your medics are using? And let me ask you another question. That was, how were you trained in stethoscopy? I really wasn't as a paramedic. So those are some of those things. So this is actually a picture of the handheld ultrasound that I have and fits in my bag. I put it in my pocket while I'm at work. This is a sonocyte. This is another one of the handheld ultrasounds. They actually go to either a tablet or a phone. And then this is what's called a butterfly. Now, the butterfly is a subscription thing. You can get it pretty cheap, but you have to pay an annual fee to get your images. And then here's some examples of, in the military, they've been using these in the battlefield. So these are some references here. The last two down there are references about use of ultrasound in place of stethoscopes. And especially that last one down there is lung ultrasound, the stethoscope of the new millennium. Yes. And so, especially with COVID, it's easier. You know that you're going to clean it because you got gel all over it. So it's actually, when the COVID hit up in New York City, there were several posts on social media by ER doctors saying, okay, who is still using stethoscopes? And most of the people were saying, I don't even have one anymore. So, I was not trained in ultrasound as a resident. So those things have kind of changed somewhat. And I'm trying to get my competence up with this. But I just wanted to share that's how I kind of make decisions like that. So, anybody have any questions right now? You can unmute. So Christian says no. Was this a helpful lecture for you guys? Okay. Well, good. Well, unless y'all have any questions or anything, I'm going to let you go. And guess what? Right on time. So hope everyone has a good evening, and we'll talk to you soon. Take care.
Have a good night.
All right, you too. Bye.